Okay, we can just give it like a couple minutes so that people join and to let people join, and then I'll let you know when we can get started.
Do you have any plans for a weekend?
Yeah, I'm actually going home for Diwali.
Yeah, me too.
Yeah.
It'll be definitely different though this year.
Yeah, definitely. I'll just be spending time with my family.
Yeah, not like all the celebrations and all that.
Yeah, that's unfortunate.
Yeah.
We can start in like a couple minutes. People are still like trickling in, so. Okay, I think we can get started. So, hi everyone. This is my medical message again. We apologize for the delay today. It was just due to technical difficulties, but we can get started right now. So this is Dr. Neena Chandrasekaran, and she is in pulmonary and critical care medicine, and she has a lovely presentation prepared for us with a lot of case studies and a lot of interesting information for us. So go ahead. Welcome.
Hi guys. Thanks for joining us today. My name, like she mentioned, is Neena Chandrasekaran. I am in pulmonary critical care, second year here at Wayne State in Detroit. So today I'm going to be talking about a little bit about what I do and going over a few cases and talking about what's on everybody's mind, which is COVID. So in pulmonary critical care, what I take care of is I take care of lung pathologies, whether it's COPD, asthma, interstitial lung disease, pulmonary hypertension, pulmonary fibrosis, any of the above, and much more. So we cover those patients and we see them as consults in the hospital, like your normal cardiology, GI, whatever consults. We see them in the hospital, and also we see them in clinic. I love the aspect of pulmonary critical care in that you get the outpatient side with the pulmonary. You can open up your own clinic and keep it going that way, just do hospital consults. But at the same time, you get the ICU experience. So the critical care part is what a lot of people go into Pulm Crit for, but they stay for the Pulm. Critical care is it's very intense. It's very hands-on. You take care of the sickest of the sick, whether it be patients in septic shock, cardiogenic shock, hemorrhagic shock, DIC, diffuse intravascular coagulation. You just see so many different things, and you are the first ones to manage them. You can get a patient admitted from the ER to you and kind of just manage them, stabilize them, and then try to get all the pieces together to see what's going on. Or you get patients from the floor who happen to be crashing. Either it's they need airway protection, they're short of breath, they need to be intubated. So I love what I do because I love both aspects. I love being able to have an outpatient side to connect with patients on a different level, whether it's their pulmonary status or just it's that human touch that you get to see them every so often, whether it's every 3 months or 6 months, you get to connect. Then I love the critical care aspect because that's the time when you get to do procedures in addition to just taking care of the sick patients. We do central lines, whether it's femoral or subclavian or jugular. So these are large bore catheters. They're triple catheters that we place. We do arterial lines. Usually radial is what's preferred, but I've done axillary before, or femoral. And those are just for closer blood pressure monitoring. We do intubations. We do lumbar punctures, thoracentesis when we drain fluid from the chest if somebody has a pleural effusion. And we also do paracentesis, and that's for fluid buildup in the stomach. So we get to do all these procedures. And at this point, we've had like over hundreds. So it's definitely cool to get both aspects. There's different ways you can do critical care if you're just going to do critical care. You can do Pulm Crit, which is what I'm doing. You could do internal medicine and then go into just critical care, which is only 2 years. And you would just be doing ICU medicine and your internal medicine if you want to continue to pursue that. You can do ER, emergency medicine, and then do critical care, and you can do anesthesia and then do critical care. So there's, and also actually neurology and then critical care. So they take care of neuro ICU patients. We do too, but they're usually primary. And this includes patients that have herniated, any post neurosurgeries, post strokes, subarachnoid hemorrhages. They usually take care, point people on those, status epilepticus, continuous seizures, all that. So it's cool. I definitely like what I do. I enjoy it. If you have any questions, feel free to drop them in the box regarding my field, and I'll be sure to answer them. So today, to get started, I have two interesting cases. So we shall begin. So case one, we have a patient, 28-year-old patient with a history of mild asthma, comes in for shortness of breath. He noticed this this is actually a real case from yesterday. So he noticed this when in deep sleep, he would feel some slight difficulty taking in and out a deep breath. He noticed that this was mainly during REM sleep. When he would just get really deep, he would kind of have to struggle to take in and out a deep breath. And this would cause him alarm and cause him to wake up. So he came to our clinic asking for what's going on / advice. He came to our pulmonary clinic. So past medical history is as above. The only past medical history this young 28-year-old has is mild asthma. And this was diagnosed 10 years ago, he said, through breathing tests. Past surgical history, appendectomy. Past family history, mother with pancreatic cancer, father with some type of lung disease, and brother with asthma. So clearly this seems to run in the family. And social history, he just smokes marijuana. I'm going to ask you guys anything else you'd like to know in terms of his presentation, what he came in with, and where we'd like to go from there. I'll give you guys a couple minutes, and if you can just let me know what other questions they would like to know in regards to this patient presentation.
Yeah. So the questions I posted in the chat aren't related to that. That's just questions in general. But yeah, we'll just give it a second because the YouTube live lags just a bit. One person said vital signs.
Yeah, that's a great question. It's always important to know the vital signs. Since he's coming into the clinic, it wasn't as terrible or as vital as it would be if he was coming to the ER. But his heart rate was 98. His SaO2 or on room air was 97%. Blood pressure 118 over 90. So all of his vital signs were relatively normal. So for the sake of time, I'm going to talk about different questions that I asked him as he comes into the clinic asking, coming in with shortness of breath. So we try to get to know what exactly does shortness of breath mean. For some people, shortness of breath could be, they're kind of sitting down, they're talking, and they're like, because it could be like a panic attack. So you're trying to elicit, is this a panic attack? Is this gradual? Is this a pulmonary embolism, meaning it's more acute and it just suddenly came on? Or this more chronic, it's been happening for a prolonged period of time. Other reasons you try to see if this is acute versus chronic, because if it's acute, that has to be taken more seriously. So we ask, when did this start? How do you describe this shortness of breath? Does it happen every night? And then you try to elicit other things that are associated with his breathing. Do you have cough, any fevers, chills, shortness of breath? Is a cough with sputum? Is it yellow, brown, blood? Are you having any weight loss? So these are important things to ask when these patients do come to specifically our lung clinic. We do ask these questions, especially in relation to their breathing. Other things that I specifically asked him, because he has this history of asthma, is trying to figure out what kind of asthma he has. Now, recently we have learned a lot more about asthma in general. We've learned that there's two different types. There's the allergic type, and then there's a non-allergic type. And this is important in terms of therapy and treatments and how we could treat asthmatics today. So we ask, when was your asthma diagnosed and how was it diagnosed? One of the most miscommon diagnoses is in the hospital in general is COPD. COPD and asthma are very commonly misdiagnosed. If you have a patient that smoked, they will more than likely be misnamed or misdiagnosed as COPD, even though they don't officially have COPD. Asthma as well. Sometimes people call COPD asthma, asthma COPD. So we ask, how are you diagnosed with your asthma? And do you guys know how you do diagnose asthma? You can write it in the chat while I continue to speak, but you guys can answer the question, how do you diagnose asthma? So he tells us he was diagnosed with asthma. Then other things to elicit to figure out if this is allergic type asthma or if this is non-allergic type asthma would be to elicit some type of symptoms that go with allergies. So one of them would be, do you have allergies? Very simple. Allergies in terms of, do your eyes water when you're around something? Do you notice some congestion? Do you have postnasal drip? Wake up in the morning and you notice that you're very congested or stuffy? Do you have to stay away from dogs or cats or birds? So we ask questions like that. For this specific gentleman, he said he's had allergies all of his life. He always wakes up with congestion. He gets rashes when he's around something that causes him to get an allergic reaction. And he said that it could be pollen, it could be mold. He's not allowed to have any pets, which is very unfortunate, but he can't have any pets. So in my mind, I'm already thinking, okay, this is allergic asthma, which is good because that can help with my treatment that I plan to put him on later down the line. So that's important to know. Other things in general that are important to know when you're talking to somebody who comes in with shortness of breath and you're trying to elicit if they do have a lung disease would be the social history. That's really important. You try to ask these people, where have you worked? Have you been around any factories? Have you been introduced to any inhalants or chemicals like berylliosis, silicosis? These things can stay in your lungs and they can cause cavities. They can cause lung disease over time. Asbestosis, that's a very big one, and that's a big board question for you guys too. If you're a cave worker, if you work on ships, then you could be exposed to asbestosis. Other things could be what part of the US you live in. There's like histoplasmosis, there's coccidioides, there's blastomycoses. So these specific fungal infections, they're endemic to a certain portion of the US. So some of the social history that's good to get is just kind of knowing, all right, I'm in the Midwest, so I would be looking for histo more. But if he had traveled to California or Texas, then coccidioides would kind of be on my mind. So it's important. Travel history is big too. Other reasons why travel history is big is if someone takes a long flight, you could be thinking about a blood clot. So it's important to know the travel history as well. So I always ask, what do you do for a living? What did you do? Have you ever been exposed to any chemicals? And pets. Pets are always a big one. Sometimes people could be living with dogs, cats, birds, and they don't even know that they're allergic to them until they start noticing shortness of breath that keeps coming on and they don't know why. We actually did have a patient who had birds, and she came to us, and she just did not mention to us that she had birds until like her third visit. And then we asked that question. I guess no one had asked her prior, but we asked her and she said she had birds. So we tested her for we tested her sputum and we tested her blood to see if she had IgEs and a RAS panel, which is a respiratory allergen sensitivity test to check for allergens. And fair and behold, she was allergic to birds, unfortunately. And she actually ended up getting atypical pneumonia, which is from chlamydia psittaci. Chlamydia psittaci is a specific atypical pneumonia caused by birds. So essentially that's what she did get. But yeah, so we asked all these questions to this patient, and it seems like this is pretty straightforward asthma. So now in my mind, I'm thinking, okay, so I got a pretty good history, and now I'm going to ask questions more geared towards the asthma. So for anybody that has asthma, we like to ask, have you ever been intubated? This is a very big and a very important question because this can tell me the severity of the asthma. Patients that are uncontrolled at times, they do need to get intubated for their asthma if they're having a very severe asthma exacerbation and they can't tolerate BiPAP. So that we asked, have you ever had any intubations? How many times have you been hospitalized for your asthma? How many times have you been treated with steroids for your asthma? And what are you on for your asthma? Other things that are important to know are things can trigger asthma. Sometimes some types of perfumes can trigger asthma. Some postnasal drip can trigger asthma. Acid reflux can trigger asthma. Anybody who has obstructive sleep apnea can trigger asthma as well. So he's young. This patient was 28. This patient was young, so he didn't have any of those comorbidities, but I still asked for fullness sake. So those are other important things for social history in addition to marijuana. Obviously, is smoking. That's huge. We always ask smoking. This has to do with lung cancer screen if they're on the older side and they're between the ages of 55 to 70, and they were a smoker for at least 15 years, and they quit in the past 5 years. We will screen them for smoking. Low dose CT scans is what we do. Other things that we do ask for social history that's really important, especially in kids these days, are that I have seen to vaping. Vaping can cause a big disease on its own. So we ask now, do you vape? In past medical history now, like nowadays, since maybe June, we've been getting post-COVID too. So I've been seeing a lot of post-COVID patients, and they all present, some present terribly, most present well though, thank God. So that's a good thing. So that's also part of the past medical history these days that we do ask. Important things for family history and lung diseases is, do you guys know of a specific lung disease that's associated with cirrhosis and runs within the family? Let's say the patient's father had it, and the patient's father had cirrhosis, and this kid has cirrhosis, and he's never drank in his life, and his father has never drank in his life. There's a certain condition that we would test for. It causes COPD and cirrhosis. So if you guys do know the name of it, please put it in the box. And I'm going to go into the chat right now to see if anybody answered that question. How do you diagnose asthma?
Yeah, if you scroll all the way down, there are a few people that.
Okay, so I'm just looking right now. It says diagnose asthma by lung function test. So you're correct. You do diagnose asthma by a lung function test. Chest or sinus x-ray? No, that won't tell you it. Any background history of pre-existing conditions or family history? Family history will push you towards it, but it won't be the absolute. That most absolute is a lung function test, and more specifically what we call a pulmonary function test, which we actually will get into in the next couple slides. So you diagnose it based off a pulmonary function test, and if that is negative, but you still have a very high suspicion, then there's one other test that you can do. I'll let you guys see, I'll let you guys answer that question if you do know it. And once again, the question is, if you have a high suspicion of asthma, but their pulmonary function test is negative, what is the other test that you can use to diagnose asthma? Did we get any questions for or answers for the question about the familial lung disease with cirrhosis and COPD?
Not yet.
Okay, so just for the sake of time, I'll tell you guys. It's alpha-1 antitrypsin disorder, and that runs in familial. It's Y chromosomal, and basically, it's an entity where you have alpha-1 deficiency, and alpha-1 is needed to cleave the elastase within the lungs and the liver. So you just end up getting COPD and cirrhosis because of this. You can treat it since you are deficient in it. You can give alpha-1, you can give the gene through injections. It's a pretty rare condition, but it is something that we screen anybody who has COPD with, even if they have a strong smoking history. Per GOLD guidelines and ATS, we have to screen everybody. Okay, so in this gentleman, this 28-year-old, let's look at his PFTs. So these are his pulmonary function tests. So what are pulmonary function tests? Essentially, they are tests that measure our lung function. And why is it important to measure our lung function? To diagnose specifically what's going on with the lungs and if it's something that we can help. Not being able to breathe and shortness of breath is probably arguably the worst feeling in the world. If you are just sitting there and you can't breathe, God forbid that happens to any of us, it is extremely scary. So we get these tests and they help us measure what's going on within the lungs. So there's two different parts. There's the spirometry, as you can see up here, and then there's the lung volumes. So the spirometry tells us a lot. Sometimes some patients can't even perform the lung volume part, but the spirometry itself can actually help us in just diagnosing asthma. Before we get into the numbers, we'll talk a little bit about lung volumes. So this is something you guys will see once you'll see in a lot of your classes, probably physiology. It has to do with just the way we breathe. So what's important to know here is this here. This is called the VT or tidal volume. This is us right now. We're breathing in, we're talking, we're breathing out. That's tidal volume. So that's normal breathing. Inspiration, expiration, inspiration, expiration. That's normal. Then on top of this normal tidal breathing, if I tell you to breathe in, so I'm just breathing normally, but then I breathe in, that's your inspiratory reserve volume. How much inspiratory volume your lungs can hold past a normal breath. So once again, we're breathing in, we're breathing out normally. Then I tell you to breathe in deep, breathe in deep. That, how much you're breathing in between your normal breath to when I tell you to breathe in deep. That much is called your inspiratory reserve volume. So we tell people to sit in this machine here, and then the RTs or the respiratory therapists yell at them. They're like, breathe in, breathe in, breathe in, breathe in, breathe out normal, breathe in, breathe out normal, breathe in, breathe in, breathe in. So they breathe in, and we measure that. So that's your inspiratory reserve volume. And this is important because let's say you breathe in only 200 cc's, but your normal is 400 cc's. That means that there's something in your lungs that's preventing you from breathing in the 400 cc's. So all these have implications. So yeah, so this is your normal tidal volume breathing, and then this is your inspiratory reserve volume, which is how much can you breathe in after your normal tidal volume breath. Then you have your expiratory reserve volume. This is how much can you breathe out after your normal tidal volume breath. So you're breathing in, you're breathing in. I tell you breathe out, breathe out, breathe out. You breathe out as much as you can. And that's your expiratory reserve volume. Okay, so putting the pieces together, you have your normal tidal volume breaths. Then you have your inspiratory reserve volume, which is how much are you breathing in after a normal tidal volume breath. Then you have your expiratory reserve volume, which is how much more are you breathing out after a normal tidal volume breath. And then under your expiratory reserve volume is your residual volume. This is the air that's trapped within your alveoli and just trapped within your lungs. And this is called your residual volume, what's left over. So this is what's just lying there in your lungs if you happen to have hyperinflated lungs because you have COPD, or you have emphysema, and then you just have gas pockets in your lungs that cannot expel the volume, and it's just there. So these are what we look at: tidal volume, total lung capacity, vital capacity, expiratory reserve volume, residual volume. So these are what we look at, and these help form our spirometry and our pulmonary function test. All these have implications. So now going back to our patient spirometry. So here you see spirometry, forced vital capacity. So what is your vital capacity? Your vital capacity is your tidal volume. So you're taking in a breath, you're taking out a breath, and then I tell you to breathe in and to breathe out. And that's your vital capacity. So it's your normal tidal breath, your tidal volume, plus your expiratory reserve volume, plus your inspiratory reserve volume. Your FVC. So in this patient, you look at any patient that when you're looking at your spirometry, you look at the percentages and the decimal numbers. Right? Okay. So you look at here. This patient is at 165% and 2.23. Okay, so here we'll just ignore the post for now and just look at the pre. So after just look at the actual predicted and percent predicted. Ignore this post bronchodilator. We'll speak about that shortly. So, all right, so looking at spirometry, so that was the forced vital capacity, and this is the forced expiratory volume in 1 second. So forced expiratory volume in 1 second, and this is liters. So forced expiratory volume here, this patient has 1.72, and that's percentage-wise 121%. Just keep these numbers in mind. But the first thing you do look at when you are looking at spirometry is the ratio. You look at the FEV1 to FVC percentage. A normal person with no lung pathology, no bronchoconstriction, no bronchospasm, no COPD can blow out 70 to 80% of their lung volume in 1 second. So that's where this 70% number comes from. So 70% FEV1 over FVC percentage, 70% is normal. So 70% and higher could indicate some type of restriction, and then below can be as obstruction. So that's the number that you look at. So going to this patient, first thing when I read a PFT, the first thing I go to is their ratio. So I say, okay, FEV1 over FVC percent, it looks like this patient is at 73%. The number 77, this patient is 73. So I'm like, okay, this patient does not have any obstruction. And then I look at if they did have obstruction, I would look at their FEV1 to see the degree of obstruction. And FEV1 is important because I was telling you guys that in 1 second, a normal person should blow out at least 70% of their tidal volume. So if I tell you to blow out, you should blow out 70% of your tidal volume in 1 second. So this patient does not have any obstruction because this percentage is not elevated. If this percentage was elevated, then he would have trouble exhaling all his air. And that's why that number would be lower than 70%, because they can only blow out 50% or 40%. And that's what we call obstructive disease or chronic obstructive pulmonary disease, aka COPD. Asthma is also an obstructive disease. So asthma and COPD are both obstructive diseases. And what an obstructive disease means is you have trouble exhaling. You don't have trouble inhaling. Their inhalation is fine. They will not have any problem with their inspiratory reserve volume, but they'll have troubles with their expiratory reserve volume. So they'll have trouble blowing out. And if it's because of COPD, then they might have air trapping. They probably have emphysema. They could have bronchitis. They can have inflammation of the smaller airways. If it's because of asthma, it's because they are also having air trapping, but their pathology is reversible. That's the major difference between COPD and asthma. COPD it's irreversible, but you can treat it. With asthma, it's reversible. So you can use beta-2 agonists or albuterol to open up the airways because it's just bronchospasms. Or you can use steroids to decrease the inflammation. You could use steroids in COPD too, but in asthma, reversible. That's the definition, a reversible airway obstructive defect. Okay, so this patient's spirometry, we look here, their ratio is 73%. So we say, okay, no obstruction. Then we go to their FEV1, 121%, 1.65. So these are, then we look at these numbers. This part is a little more advanced, but for what you guys should know for your boards and for just when you're thinking and looking at this, look at the ratio and make sure it's either 70% or greater, because if it's lower than 70, then that's gonna indicate a likely obstruction to you. We'll go over a couple other PFTs, but for this gentleman, we'll focus on what we think is going on with him. So we have 73% here. And when you are going to diagnose asthma based off spirometry, you need a 200 cc positive, you need an increase in 200 cc's within your FVC or your FEV1 plus a 12% change. So 200 cc's, what does that mean? That means here you have 1.72 and then here you have 2.53. So that is a positive 200 cc change in your FEV1, and that's a 21% change. So he meets the criteria for asthma defined by positive 200 cc within the FEV1 and a 12% change. Now, what exactly does that mean? That means that when you do a spirometry or pulmonary function test, you do a pre-bronch and a post-bronch. Bronch is bronchodilator. So you test these volumes prior to giving 2 or 4 puffs of albuterol. And like we said, albuterol is a beta-2 agonist. So we test these volumes, and then we tell you blow in, blow out, blow in, blow out. We measure how much is going in, how much is going out in this weird contraption chamber thing. We record the volumes. You can see them being recorded here. So then we stop, we give albuterol, and then we record them again. So what you can see here is before albuterol, this patient was only able to blow out 1.72. After we gave this patient albuterol post bronchodilator, he was able to blow out 2.53% because it's the forced expiratory volume. So he's able to exhale in 1 second at least 2.53, which is way better than 1.72. And in fact, that's greater than 12% change. So he meets the criteria for asthma. And what does that mean? That means it's reversible. Without bronchodilators, he can't blow it all out, but with bronchodilators, he can. So just to go over it, you need a 12% change in either your FEV1 or your FVC, and you need 200 cc lung volume change. So that's when you look at here, this predicted, and then this actual between the pre-bronch and the post-bronch. We'll get into lung volumes in a little bit. So when we do measure people's their lung function, we also do a flow volume loop. A flow volume loop is important because this kind of tells us what's going on within their lung pathology as well, whether they have severe obstruction or they have mild obstruction or they have some type of intrinsic lung disease versus an obstructive lung disease. So here you can see for a normal person, this is how it should look. And what's interesting on the flow volume loops is the top part's the expiratory and the bottom part's the inspiratory. So this is inspiratory, 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 expiratory. So you're inhaling and then you're exhaling. And then that used to be very confusing for me when I was first learning these, because I'm like, why would exhalation be on top and inspiration be on bottom? But if you train yourself now to like just look at these that way, then it will help in the long run. So a normal person can breathe in normally with no problems. You see no flattening here. You see no curves here. It's just perfect inhalation. And you don't expect any problems in inhalation in somebody who has an obstructive process, because like we were saying, an obstructive process during exhalation, not inhalation. So if you see this bottom part being normal, then then they shouldn't have any problems with their inspiratory effort. That's inspiratory. Then expiratory. This is where you'll see the problems. In somebody that has obstructive diseases, as you can see here, mild obstructive asthma or COPD, compared to a normal person, they're taking longer to exhale. And then here, they're even taking even longer to exhale. And we said that goes with forced expiratory volume. and force vital capacity because they're just taking longer to exhale. And then that's pretty much what we see here. And this is severe. This one is like super severe. So we say exhale, and then we said in 1 second, you should have 70%, if you're normal, you should have 70% of your tidal volume exhaled. And that's what we call that peak, is called peak expiratory flow. So that red part, that top here is your peak expiratory flow. In patients with severe obstructive disease, they reach their peak expiratory flow very quickly, but they don't exhale all of their 70% of their lung volume. It takes them a very long time to get back to baseline. So that's pretty interesting here. So these three here are obstructive diseases: mild, moderate, and severe. You can see that what's interesting here is your mild, it's not terribly different from a normal, just slightly. Then you have obstructive, and you can see it more caving in. And then by the time it gets to severe, it's completely coved. We call this coving, severe coving. And the reason is, like I said, because they reach their peak expiratory flow very quickly, but then it takes them a very long time to exhale. So this is severe obstructive disease. Now, the difference between obstructive versus a restrictive disease, and obstructive versus restrictive, is just lung volume. So here you can see that this shape in a restrictive person is completely normal. They're able to inhale and exhale properly, completely normal. The only problem is they have so much restriction, or there's just something causing them to not have enough lung volume. So they can't expand as big and produce as much tidal volume as somebody who does not have restriction. So that's why they don't go all the way here. And this is your leader and your volume. So flow and volume. So a normal volume should be here, 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 but theirs is more in because they can't exhale and inhale fully. So they don't inhale fully, they don't exhale fully. And that's just because they have something like pulmonary fibrosis. They have a neuromuscular disease causing chest, causing them to, like ALS or Guillain-Barré or myasthenia, where they just can't inhale and exhale fully, or like pulmonary fibrosis that's causing the lung volumes to be decreased as well, or they have scoliosis, or they have obesity. These things can cause some type of restrictive lung disease. So that's pretty much the restriction component. If you ever see flow volume loops and then you see a problem on the top, remember that's obstructive. If you see low volumes in general, that's restriction. Then the bottom part, like we said, is inhalation. So if you see a problem with the bottom parts, you're going to know it's either extrathoracic or intrathoracic. And that means that there's tracheal stenosis. Somebody is born with just a narrow trachea, or they have inflammation post intubation. So there's still a lot of inflammation within their trachea. And our trachea is like our main, it goes from our throat and it connects to our lungs. So that's the major part, that's our major airway that we use to breathe in and out. So if there's inflammation in that area, then that can also give you some narrowing on the inhalation loop of your flow volume loop. This is kind of talking about like what we spoke about. So pretty much you exhale and you have your peak expiratory flow. That's the maximum that you exhale in 1 second. That's your peak expiratory flow. Normal people go up to here. If you have your peak expiratory flow mildly reduced, but it's taking you longer to exhale, then this is going to be obstruction, just like we spoke about. If it's severely reduced, you can't reach your peak expiratory flow as high because you just are having trouble exhaling, and it's taking you long, then that's severe obstruction. And here's restriction. You just don't have as much volume because something is blocking. And then this is, like we said, this is the inspiratory component if there's a problem with that. And this is if it's fixed airway obstruction, meaning you have a problem with both your inspiratory and your expiratory. This is rare. You usually see this if, like we said, you have tracheal stenosis, because then that will cause you problems when you're breathing in and breathing out. Or you have a tumor that's blocking your, like the laryngeal tumors, that can cause that as well. So getting back to our criteria for COPD. So here you're looking, we said you blow out 70% of your tidal volume in 1 second. So if it's below 70%, then you know that there's an obstruction. So here, if it's 50 to 70%, you're here. If it's 50 to 30%, you're here. And then if it's below 30%, you're here. And by here, I mean gold stages. So you have gold 1, gold 2, gold 3, and gold 4. Gold 4 is your most severe. And this is your FEV1 less than 30%. This is your FEV1 is between 30 to 50. And this is if it's between 50 to 80, but you have a ratio less than 70%. This is important for treatment. And this gold is talking about COPD, not asthma. This is kind of going through just a pattern for looking at PFTs and kind of how you diagnose them. So like we said, the first thing you look at is your ratio, and then you see if it's below. So if it's below, then you're going to think, all right, obstruction. So then you can look at your FVC. If your FVC is normal or high, then you would think more towards an obstructive, and it could be emphysema or bronchitis. Things that can help differentiate these two will be our DLCO, which we'll talk about in a little bit. And then if your ratio is normal or high, then once again, you'll look at your FVC, and this can kind of help tell you if it's restriction, if you have a low TLC, which means that you just can't breathe in and breathe out because something is blocking, whether it's pulmonary fibrosis or neuromuscular disorder or chest wall disorder or a pleural disorder. So looking at the DLCO, this is diffusing capacity of carbon monoxide. So it's basically how quickly carbon monoxide can diffuse into our hemoglobin and then pass into our bodies and into our cells. And the reason we use carbon monoxide is because that has a very high affinity for hemoglobin. So this DLCO is a measure of the overall function of the alveolar capillary membrane. So in order for something to diffuse through this is our trachea, and then there's the right main stem bronchi, and then our left main stem bronchi. From there, it branches out like a tree, is how I describe it to my patients. I say our lungs are like trees. So you have your branches or your airways, which are our bronchioles, and then it goes into your leaves or your alveoli, your alveolar sacs. And then there, blood vessels will pick up the oxygen, because what's the point of the lungs in general? The point of the lungs in general is to oxygenate the body and take away CO2. So you have blood flow through your superior vena cava, then your right atrium, then your right ventricle. From your right ventricle, it goes through your pulmonary vein into your lungs, then your pulmonary artery into your left atrium. So when it goes into your lungs area is where it gets the oxygen. And that's very important. This is very important in terms of your oxygenation. If that membrane, the alveolar capillary membrane, is very thick, then you'll have problems getting oxygen into your red blood cells and into your body in general. So that's one thing. If it's thick, so you look at the thickness of the membrane. That's really important. Another thing is the surface area. This is the equation for the diffusion. It's a little above what you guys need to know, but this is pretty much what we look at. So we look at the thickness, and things that can cause a thick capillary alveolar membrane could be fibrosis. So if there's fibrosis there, then that would be very thick. If they have a connective tissue disorder that's once again causing fibrosis, then that can cause a thick membrane and decrease DLCO, meaning you won't be getting the oxygen you need for your body. Other things that can cause it is surface area. So let's say some patient had lung cancer and they took out a lobectomy that they had. Because in your right lung, you have 3 different lobes, and your left lung, you have 2 lobes. If you take out one lung, you could still live. But that helps, or that worsens your DLCO, because you just don't have enough surface area to oxygenate all of the alveoli and all of the red blood cells that are trying to move through the lungs, because there's just no lung. So surface area is 1, thickness of membrane is 1, and the rate of gas diffusion is 1 as well. Rate of gas diffusion and partial pressure gradient, that's another one too. So you know how they said altitude matters. So altitude can matter too in terms of the barometric pressure. So if you're in a higher altitude, the barometric pressure is just going to be different due to the environment and what's around you. Other things that can affect the diffusing capacity of carbon monoxide is anemia. So if somebody has a lower hemoglobin, they're not going to transmit as much oxygen to their organs because they just don't have enough carriers of the oxygen or hemoglobin. Because anemia is by definition low hemoglobin, so you don't have enough cars, let's say, to transport the people or the oxygen. So that can definitely affect your DLCO as well. So this is pretty much what we talked about. Low DLCO, emphysema, because you have your surface area changes with emphysema. Not all of the areas of your lungs are going to participate in gas exchange. That's emphysema. Increased membrane thickness, like interstitial lung disease, just like we said. Pulmonary hypertension too. That's so you have normal hypertension in your heart when your heart is pumping, and you have high blood pressure. That can cause left ventricular hypertrophy or just hypertension of your body. There's also such thing as pulmonary hypertension, high blood pressure in your lungs. This can happen if you have right-sided heart failure, or if you have left-sided heart failure that can then become right-sided heart failure. Essentially, your lungs are working overtime. When this happens, they can become thick. The pulmonary arteries can become thick within themselves. The intima can grow within itself and cause pulmonary hypertension. Anemia, like we said, if you have low hemoglobin, you're just going to have low diffusion capacity because you don't have enough carriers to move the oxygen. Increased DLCO is something that's possible too. You can see this in things like polycythemia because you have too many carriers of oxygen. You have too much blood. So you have too many RBCs. That's polycythemia. Poly is many, cythemia is blood cells. So you have a lot of red blood cells in your body. Pulmonary hemorrhage can cause this in it's like a false positive because so you have blood in the lungs. So you have blood in the pulmonary arteries and in the lungs in general. So all that blood that's there, that's hemorrhaged, is picking up all this carbon monoxide, but it's falsely high. It's not really high. It's just because there's blood there when it should not be there. Asthma, the reason why asthma is not really highly understood, but it does have to do over time with patients that do use bronchodilators. They just get a lot of expiratory and just bronchodilation. So it's not very well studied as to why the increase in DLCO happens, but it is a board question. And then exercise makes sense because your body is demanding more oxygen. So when you're demanding more oxygen, you're moving blood, and when you're moving blood, you're moving hemoglobin because hemoglobin is in your blood cells. And when you're moving hemoglobin, the DLCO increases because that's where the carbon monoxide goes. Carbon monoxide goes to the hemoglobin goes to the body. And in times of exercise, you need more. So getting back to asthma is a long-term inflammatory disease of the airways. It is characterized by variable and recurring symptoms, reversible airflow obstruction, and it's easily triggered by bronchospasms. So what's important to know about asthma is the problem is, like we said, it's a reversible airflow obstruction. You can treat it, and you can get a lot of wheezing, which is bronchospasms. So if you think about the lungs being like a tree, you have your airways, then you have your bronchioles, then you have your alveoli. If your bronchioles close within itself, that causes wheezing. It's like your airways are trying to open, but there's obstruction because of all the inflammation. And that triggers the sound of wheezing. It could be because of environmental factors like we were talking about. It could be genetic, it could be triggers, and it could be the environment. This is how we classify asthma: intermittent, mild, chronic persistent, moderate, or severe. And this just depends on symptoms, if you have daytime symptoms or nighttime symptoms. We give patients a peak flow. I give this to all my asthma patients, and I tell them to do this on a good day. Your peak flow is how much you're able to exhale. Like we said in a second, you should be able to exhale 70% of your volume. So if you can exhale 300 cc's today, but then tomorrow you can only exhale 150 cc's, that's half the amount of tidal volume you could have exhaled the day before. That's concerning. That's when you would call us, your pulmonologist, and we would prescribe to you steroids, and we would also prescribe more bronchodilators. So that's when you know that that's a problem. Persistent asthma, this is just our treatment. Normally, we start out with albuterol. That's a short-acting beta agonist, inhaled short-acting beta agonist. And then if you need to go step-up therapy, then we add an inhaled corticosteroid. And then if you need to go again, then we'll do just a longer-acting beta agonist in addition to the inhaled corticosteroid, or we'll switch the dose of your inhaled corticosteroid. So that's kind of just how it goes and how it progresses. Usually, if we have patients in the very, very severe category, then we'll consider our monoclonal antibodies. And these are our monoclonal antibodies. So T2, this is the allergic type asthma. And Allergic type asthma means it's mediated by a lot of cytokines, a lot of interleukins like IgE, IL-5, IL-4, IL-13. We have treatments such as omalizumab, mepolizumab, rezulizumab, benralizumab, dupilumab. These we treat, we use them. Nucala is a drug named Duxepent, Xolair. We use these. So you can block one of these by giving them one of these medications. It's an injectable once a month. And this helps. This just really helps patients. A lot of patients have a lot of better quality of life with these medications. So now going back to these PFTs, I'm going to let you guys tell me what you think. So just type in there. When you're looking here, this is just a spirometry. First thing you look at is your FEV1 to FVC. Here you go to percent predicted. You see it's 33%. 33%. That is sad lungs. You can tell that that person cannot exhale. Then you go to the forced expiratory vital capacity in 1 second, and you see that's only 17. You should be doing 70, well, the percent should be 70%. And here you should be doing anywhere from 70 to 80% in 1 second. And this patient's only doing 17. That's bad. This patient has severe obstructive disease. This is the CT scan of that patient. As you can see, this patient has these bulli is what we call it. They're big air sacs and they're just filled with air. All that black there is air. And this is a patient that has emphysema. This specific part of the lung is not participating in gas exchange. And we said patients that have emphysema, they have a decreased DLCO because not all of their lung is participating in gas exchange. And if it's not participating in gas exchange or oxygenation, then the DLCO is not going to be counted in these parts. So it will be low. This is another PFT. So here you go to the ratio, you see it's 77%. So it's greater than 70%. So then you can go to the FVC here and you go to the FEV1 and you see both of them are reduced, but the ratio is not. So then you're thinking in your head, why is the FEV1 reduced? Why is the F and the FVC, but the ratio is normal? So then you can look at your total lung capacity. You see your total lung capacity is low. So this is pointing towards restriction. And then you can look at the DLCO, which is very low, 48. That's on the lower side. The patient should be, predicted value should be 20.32, but the patient's only 9.84. So that's 48%. So this patient has low DLCO, has low TLC. So total lung capacity is low, DLCO is low, ratio is normal. So this points towards restriction. All right, guys, getting into our next case for the sake of time. So we have a 32-year-old female, history of diabetes, hypertension, comes to the ER for shortness of breath. Very tachypnic on exam, diaphoretic. Cannot elicit too much information from patient. Husband comes and says they were at a party last week. This is a real case as well. Some of the things were changed for HIPAA purposes, but this is what we are seeing today. Vital signs, heart rate's 125, blood pressure is 180 over 110, satting 78% on room air, respiratory rate's 38. So these are the patients that I'll get in when I'm in the ICU. So I did one palm case, and this is like a intensive care unit ICU case. So what else do you want to order? For the sake of time, I'll just talk. So this patient's coming in and is very uncontrolled. You can see that they're just breathing very heavy. They're sweating. Their blood pressure is so high because they just can't breathe. And even though they're trying, they're only 78% on room air. So the first thing you want to do before you do anything is ABCs. That will always be, no matter what field you go into, no matter what you do, it's ABCs. A is your airway, B is breathing, C is circulation. So you need to get this patient an airway, or you need to make sure that they're breathing properly. You can start them on, you could do nasal cannula, but nasal cannula only goes up to like 10 liters. So we would put this patient on BiPAP or CPAP to help them right away. And if they fail BiPAP, then they're going to get intubated like right away. You order things like EKG, you order blood work, you order chest x-ray. Those are going to be your three first and foremost things to order. Blood work could wait. I mean, you try to get it as fast as you can, but chest x-ray, you'd like to order to see if something crazy is going on. EKG as well, to see if this person's having a heart attack. Is this patient having a pulmonary embolism? Is this patient having a very severe pneumonia? Is this patient having an asthma attack, a very severe asthma attack? Is this patient very septic and septic shock? Those are, is this patient having an aortic dissection? Those six, or is this patient having very severe COVID? Because, these days, and they were at a party. So these are like the 7 things that can kill you very quickly. So those are the things that you want to think in the back of your mind. So this is a chest x-ray. Just so you know, this is normal. Clear lungs. You just see a little bit of vasculature here, but it's clear. And look at this patient. That's bad. Very, very bad. There's barely any room here for gas, for oxygenation. All of this is just completely opacified. So if you guys guessed COVID, you were right. This is a patient that we had with very, very, very severe COVID. Came in, unfortunately, very young. You can see 32, had the risk factors, diabetes, hypertension, was at a party, not wearing a mask, 78% on room air. So we got the chest x-ray. We knew that this was terrible. So we ended up intubating them right away, actually, with this chest x-ray. And we got some blood work. As you can see here, what we do look at in COVID, or the COVID labs, would be your ferritin, your D-dimer, your CK. So you get ferritin, LDH, CPK, you get a lymphocyte count, you get white blood cells, procalcitonin, PT, PTT, INR, D-dimer, troponin, BNP, echo, ultrasound, comprehensive metabolic panel, and glucose. And you get all these, most of these are inflammatory markers. And we'll get into what COVID does and what COVID is. So why is COVID bad? How is it transmitted? Why should we be wearing a mask? When you cough or when somebody talks, there's a lot of airways and a lot of droplets that gets into the body. How? By the eyes or by the nose or by the mouth. Virus enters primarily through the nose, but it can get in through the eyes and the mouth too, which is why they're also recommending face shields or goggles. So when I'm in the ICU, you'll see me always with a face shield or goggles. My hair will be tied, and I'll be wearing double masks. So this is the virus. I'm sure you guys have taken immunology or like virology or microbiology. If you haven't, you will. So this is the virus, very much like the flu virus. So it's an RNA virus. SARS-CoV-2 is what we call it, or SARS coronavirus 2. Here around the virus, it has spike proteins. So spike proteins, this is how it attaches to our ACE2 receptors. Our ACE2 receptors are found in our lungs and in our heart, and in some of our vasculature as well. So ACE2 receptor. So this SARS-CoV-2 attaches to the ACE2 receptor by the spike protein. Now, treatments these days, like the monoclonal antibodies that you've been hearing on the news that President Trump got and that they just got emergency use authorization for, the Regeneron one is attacking these spike proteins so they won't attach to our cells. But anyway, spike protein. So it attaches to the spike protein and then it binds to our ACE2 receptor. When that binds, the virus then enters the cell body. So it enters the cell and it releases its RNA. This RNA that's within the SARS-CoV-2 virus gets released into our cells. Our cell's host ribosome takes the RNA and essentially it replicates it. So our bodies take this virus, takes the viral RNA and replicates it. And we keep replicating, we keep replicating it. We create new virus particles and then we release them. And that's what happens within the cells. What happens when we release them? Well, because I said that the ACE2 receptors are within our lungs, very, 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 very high prevalent within our lungs. It affects our lungs. Very high percentage of patients get respiratory symptoms because of this. So normal lungs, before we talk about what it does do in the lungs. Like I said, it's like a tree. You have your trachea here, you have your right main stem bronchus, your left main stem bronchus. And then from our bronchi, it branches out into your bronchioles. And then these are your bronchioles. And then it goes into smaller smaller bronchioles and it goes into alveoli. So within our alveoli here, you have two different types of cells. You have your type 1 alveolar cells and your type 2. Type 2 alveolar cells produces surfactant. Surfactant is needed to keep the cells, to keep lining within the cells and keep them open and keep them opening and closing, because that's their job. So when COVID or the virus particles gets into our cells and gets into our lungs, we get destruction of the type 2 alveolar cells. So these type 2 alveolar cells are not producing surfactant anymore. And because they're not producing surfactant, the alveoli just get filled with debris. And when the alveoli get filled with debris, they become pneumonia or ARDS, and it starts to look like this instead of this, because of all the small alveoli here are getting filled with stuff. because the surfactant is not being produced, and it's not helping it. So then when that happens, the destruction, you get tissue macrophages, you get massive macrophage infiltration, and then the macrophages are not normal to the body. And when this happens, you get a lot of cytokines and interleukins. So what we get, the cytokine storm, interleukin 6, TNF alpha, interleukin 1, IL, all the things that they're trying to test now, tumor necrosis factor. So then these all come and kind of just try to attack the macrophages. But at the same time that they're attacking the macrophages, they're attacking our lungs. And so it's a vicious cycle. That's why COVID is bad. So how does it, we already spoke about, it goes into the nose, mouth, or eyes, and it goes down to our alveoli. And here you could see you don't get, you don't have your surfactant. And so that then causes infected type 2 alveolar cells. That then causes the alveoli to fill up with fluid, fill up with debris, fill up with protein-rich fluid. And then what happens when this fills up? It doesn't participate in gas exchange. All these cells that are trying to go through the alveolar capillary membrane, like we spoke about, these RBCs are trying to get the oxygen from the alveoli like they're supposed to. They just can't because the alveoli are filled with stuff. So all these red blood cells are just going off without getting oxygenated. And when they're going out without becoming oxygenated, you get impaired gas exchange. That's why patients come in with 70% oxygen, 78%, 60%. It's because their blood cells are not getting oxygenated because of impaired gas exchange. So in addition to respiratory symptoms, COVID affects almost every single system. It affects the brain with headaches, dizziness, encephalopathy. There have been 7 reported cases of Guillain-Barré. You can't smell, you lose your sense of smell. Gives you strokes. Renal gives you a severe acute kidney injury. It causes liver dysfunction. It causes diarrhea symptoms, nausea, vomiting, abdominal pain. It causes a lot of blood clots. It causes heart disease, heart attacks. It causes arrhythmias, endocrine. It causes high blood glucose, and derm. It causes all these weird derm manifestations that we still don't even know. So this is what the big thing is now. And this is pretty much what I was dealing with between March to May. And we have started to see it again, unfortunately. So stay safe. Hopefully there's a vaccine soon. Continue to mask up. Wash your hands and social distance. But I hope that was informative to you guys. I'll take questions now. A journey of 1,000 miles begins with a single step. I love this quote so much because it's so important. Here's my contact information. If you guys have any questions, my Instagram is Neena. You can follow me there. I do put up a lot of questions and talk about what I see and do. That's my email. And then I have a website. So you guys can reach me with any of those, and I will be free. I will be happy to speak to you guys. Mm-hmm. If you have any questions. Okay.
So I posted their questions in the chat. There's quite a few. So you can just pick and choose which ones you want to answer.
Okay. Yeah. What's the difference between critical care and emergency medicine? So ER, emergency medicine is ER. You see anything and everything that comes through the ER. To come to critical care or the ICU, you have to be very sick. You have to be requiring blood pressure medications. You have to be intubated. You have to be on drips to help bring up your blood pressure. Emergency room, they take care of anything. If you have a cold, they'll see you, give you a Z-Pack and send you home. If you have a sprained ankle, they'll treat your sprained ankle and send you home. Critical care is the ICU. You need a certain criteria to get in. How often do patients feel depressed after hospitalization in ICU? It's a great question. That's it depends what they're in there for. There are such thing now as post-ICU care syndrome, PICS, and patients that have had ARDS, acute respiratory distress syndrome, even patients with COVID that have been intubated for days and days, it's very high rates of depression after prolonged hospitalizations in ICU. If you come to ICU for something as simple like DKA, diabetic ketoacidosis, we fix your blood glucoses and you go home, then that's like a day or two stay. But it's very high after a prolonged stay because also you don't have many visitors. It's kind of dark, like there's not many windows. So we try our best to do what we can, but depression is pretty high rates after a prolonged stay. How many patients enter the ICU on a daily basis? That really depends. Now with COVID a lot, I was on Saturday and Sunday, and between Saturday and Sunday, I got 9 admissions. So it could vary, depend. Some days we get 0, some days we get like 20. It can be a lot. Is there a mental health care facility staff that works with ICU patients during their stay? Mental health care facility staff? No, actually. There's us. There's physical therapy, occupational therapy, but no mental health care staff. If we feel like the patient is severely depressed, that's like contributing to their illness, or they're very agitated, we will consult psych, but otherwise, no. What is your most interesting case? Honestly, I had a cardiac tamponade. That was pretty interesting. Cardiac tamponade is when you get fluid around your heart and your chest wall, and it just prevents the heart from beating. And it causes tamponade is what we call it, meaning the heart just doesn't pump. And that can lead to low blood pressure, and it can cause JVD, your jugular venous distension, and you need to put a needle to the heart to drain the fluid. So that was pretty interesting. And then other than that, COVID's been nuts. What are the most common critical care treatment plans, procedures that have been used during this year? Common critical care treatment plan. This year is a very weird year with COVID. So normally what we do see, if your question is what do we normally see, we see a lot of diabetic ketoacidosis. That's when patients with diabetes have glucoses in like the 500s, 600s. We have to put them on an insulin drip. And then they're managed for Q every 1 hour. We'll get their blood glucose. Well, the nurses will get their blood glucose sugar to check what it is. And then we titrate the drip appropriately. So that's a very common ICU admission. Another is septic shock. So if a patient comes in and they have an infection, it just gets very out of hand. There's different degrees. There's sepsis, then severe sepsis, then shock. And that's because of an infection, and you have to meet SIRS criteria, meaning your heart rate has to be greater than like 110, your respiratory rate needs to be greater than 28, your blood pressure needs to be lower than 100 over, I don't know the exact numbers, but there's 3 different criteria that you need, and that would define SIRS and sepsis and severe sepsis and shock. What is the worst case you dealt with in terms of pulmonologist treatment? Worst case, we did a procedure for lung cancer. So there was a patient that had a nodule, just like a spot on the lung, a nodule, and he was a smoker. So we went in with a bronch. So GI does like endoscopies and colonoscopies. So they'll go into the esophagus, or they'll go in from like the rectum to go above and below. We go into the lungs with the camera. So it's called bronchoscopy. So we did that to a patient, and then we took a biopsy. So we took a piece of the lung, and the patient just bled. That was a worst case I've dealt with as a pulmonologist treatment. So when the patient just bleeds and bleeds, you gotta, it gets very complicated. They're already intubated, so you can just single lung ventilation. If they're bleeding on the right, you put them on the right side so the blood just stays on the right. Then you move the endotracheal tube to the left side, and then you single lung ventilate. So you oxygenate and ventilate that left side, because a person can live with one lung, essentially. How has COVID affected your day-to-day schedule? Very much so. We've had less of those procedures because of aerosolization. Now, because I am pulmonary critical care, and COVID is a disease, pretty much, it's a disease of everything, but it highly affects the lungs. So we see a lot of COVID. What is the most emotional case you've been involved with? That's a great question. Emotional would be more for COVID. Seeing these patients and not having them see their families is really rough. Just, you're the only person they see every day, in and out, and it's heartbreaking. They can't be like, even if it's young patient, they can't see their family, they can't see their parents, their loved one. It's hard. You just hold up a phone to them and you're like, hope they see that. And even when they see you, you're wearing so much stuff on your face that they don't even know who you are. And you have these patients for days on end that are just sitting there, and you're coming in and out like a robot, and they're just like, it's sad. I would say COVID has been probably the most emotional cases. How do you connect with patients without becoming too attached? If you figure that out, please let me know. That's probably one of my my things that I have to work on, getting attached to patients. I think as I've been growing through my medical career, it's been getting better, and not because I'm less connected to them, but it's because I oversee so many that my residents are the ones that talk to them on a day-to-day basis. I'll step in if there needs to be a higher up to speak to them, but I get really emotionally attached, so it gets hard for me. But the best thing to do is set boundaries in your mind before and try to compartmentalize, is what I've been told. Is there any other subspecialties that you considered before deciding on palm crit? Hemonc. I thought about hemonc, but everybody kind of dies in hemonc. I mean, they live. Okay, I shouldn't say that. They live, and there's a lot of new cool therapies and stuff, but palm crit's the way for me. I love all of the action in the ICU plus the outpatient way. And honestly, you're like the go-to of everybody in the hospital. Anything happens, they're like, call ICU. You need a tube a patient, call ICU. Someone's bleeding from their nose, their mouth, their ears, their eyes, call ICU. Sometimes I'm like, I don't know any more than you do, but sure. At least I can stabilize them, I guess. How do you think palm crit will change in the future based on advancements? I think palm will change a lot because of, in terms of our procedures we do with lung cancer, there's going to be robots and there's just more and more technology. So we're better able to map our ways of how we're going to go into the lungs and obtain that biopsy. Critical care. With COVID, I think it's going to change because there's a very big need. So probably add in more NPs and stuff. I'm not sure. Why does asthma resolve in some patients and other continues into adulthood? That's a very good question. Why does asthma resolve in some patients and continues into adulthood for others? Honestly, that's a question that goes into gene therapy and into the genetics, into genomes. And that's what they're trying to target these days. Even with COPD, they're going into the genome level and trying to see, are some people more susceptible to this in the future, more susceptible to recurrent attacks because their genome is they're just sequenced that way. And unfortunately, I wish I had a better answer for you, but that's just pretty much what it is. Also, some people are more exposed to triggers that they just don't know. Like if that 28-year-old never got a RAST panel, which is the respiratory allergen sensitivity test, if he never got that and he was allergic to perfumes and he's been using the same perfume, he never even knew, then, you need to know what you are allergic to stay away from it. You need to know what triggers you to stay away from it. Otherwise, if you had it in childhood, then you have it again in adulthood. Maybe you didn't realize that you were allergic or something of that nature was triggering you. How does your workday look like as a pulmonary critical care doctor? So when I'm palm crit, I don't do palm crit at the same time. I will do a month of critical care, or I will do a weekend of critical care, or 2 weeks of ICU, because ICU is 12-hour days where you're always on your feet. You're doing procedures right and left, forward and center. You're thinking hardcore on what can I do to help this patient. These patients are literally dying. They're on the brink of dying, which is why they're in the intensive care unit to begin with. Your mind is being exhausted. You're worked. It's different. You're using ultrasound. You're lining patients. You're doing procedure after procedure. You're talking to families. You're figuring out what's going on. So you don't do palm and crit at the same time. So when I'm doing ICU, I'm only doing ICU. When I'm doing pulmonary, I'm doing pulmonary, but there's a lot of subspecialties of pulmonary, which I love. So there's pulmonary clinics, like there's interstitial lung disease clinic, then there's sarcoid clinic, then there's COPD clinic, then there's asthma clinic, there's lung nodule clinic, there's lung cancer clinic. There's just so many varieties in it that I love. As a normal pulmonary day, if I'm on pulmonary consults, then I go to the hospital around 7:30 a.m. I have residents under me. They'll see all the patients and then discuss with me. They'll be like, okay, 60-year-old is here for XYZ. We are consulted for, I don't know, pneumothorax. They have air in their lungs and we're consulted for chest tube management, something like that. They'll talk to me and we'll come up with a plan together. There's a lot of questions, guys. How has COVID changed the way you practice medicine? I see this question was asked before. How has it changed? I'm more careful in terms of sanitization. My hands are so dry from all the sanitization. I have to gown up before every encounter. I have to think COVID as a differential. It's not as easy as before. It's definitely not as easy as before. You can connect. I would say a lot of people, it's changed physical exams. in the ICU as well. If somebody's a COVID PUI person of interest, then a lot of people won't do a full physical exam on them. And that can determine, that can sometimes, be a problem because they can miss things. If you had the option, would you keep the same job you have, or would you rather either change to either subspecialize in critical care? Nope, absolutely not. I would keep Palm Crit 100%. I had the option to just do critical care, but I didn't want to. I love pulmonary, what I do, and critical care. What 2 words would you use to describe your job? Awesome. Awesome and fun. You gotta love what you do. Why do asthmatic patients experience exacerbated symptoms in the middle of the night? That's a good question. So, when people are sleeping, they're more prone to experiencing symptoms just because of the position of ventilation when somebody is lying flat. When they're lying flat, oxygenation diffusion with the Western mark zones goes to the dorsal areas. They don't go to the ventral areas unless you're a belly sleeper. Then because of that, it's not spread out as evenly throughout the whole lung. And then that can cause some areas to clamp down or get exacerbated by bronchospasms more than if they were up and about and walking around. And that's actually another reason why with COVID, we tell people to prone or sleep on their belly to help ventilate and oxygenate and have blood move throughout the whole lungs, all of the lungs. I think that's about all the questions I have time for, guys. Thank you so much for attending. If you have any questions that I have not answered or you'd like to follow me, here's my contact information. Please feel free to definitely reach out. I'm very approachable. And this was great, guys.
Yep. Thank you so much for joining us. Again, if you have any questions, be sure to DM her on Instagram or email her. Or if you want, you can also comment your questions on the post that we have, our promo post for Dr. Neena. So if there isn't anything else, thank you so much for being on our platform. Thank you so much for speaking to everyone. I'm sure everyone enjoyed your presentation as much as I did. And yeah, thank you.